Welcome to this rtx1 Users Symposium. Thank you for joining, and it is an honor for me to introduce the chairpersons of this meeting, Dr. Daniela Bacherini and Professor Paulo Stanga. Hello. Thank you so much for being here with us. Hello. Today we have a great program on adaptive optics retinal imaging with 12 speakers from 8 different countries. This meeting will be organized in 4 sessions, and there will be time for discussion at the end of each session. We invite you to type all your questions in the Q&A. And now Daniela Bacherini will introduce the first session. Thank you very much.
Thank you, Nicola. I want to thank, first of all, Imagine Eyes for this opportunity. It is an honor and a pleasure to moderate this interesting session together with Professor Stanga, and it's a great honor. And I'd like to thank all the speakers for their great contributions. And we are in a great era of continuous evolutions in retinal imaging, and adaptive optics is a fascinating technique that allows a real-time imaging of the retina, making it possible to image photoreceptors at the cellular level. So we will see important opportunities given by these techniques. And I'd like to introduce the first speaker, Dr. Friedrich Kortuem from University Hospital of Tübingen with adaptive optic ophthalmoscopy retinitis pigmentosa typical patterns. Thank you, Friedrich.
So, thank you very much for the invitation. I'm very glad to participate as well, and I would like to report on typical patterns we found in retinitis pigmentosa patients. We roughly examined 180 patients with adaptive optics, and we could define 5 different patterns that we saw repetitively in our patients. That's unspecific atrophy, central visibility of cones, atrophic pigment, clumping, puffy cones, and Cheetah pattern. So I would like to start with unspecific atrophy. Normally it's characterized by dark patchy atrophic zones. I guess everybody of you saw that already, as it's not very typical just for retinitis pigmentosa patients, but can be found in any broader or vaster photoreceptor degeneration. And I would like to point out this bigger AO image, and then we just, I did enlarge 3 different brackets, and it's also linked often with epiretinal membrane, and so it's very unspecific. The second one is central visibility of cones. As you all know, probably normally due to an insufficient resolution in a very central area of the macula, the cones can't be displayed. However, for RP patients, the density of cones decreases, and it's remarkable that you see a kind of mosaic, even if it's not as dense as normal patients, it's visible. So that's the second one. The third one would be atrophic pigment clumping. There are well-defined regions of atrophy that the pigment basically lines, so it forms the borders, and it's good to also follow up that on RP patients. The first image on the left shows baseline examination, and after 9 months we could document that clumping increases over time. And in OCT imaging, this is not as well defined and not as good visible as in AO imaging. Then we described puffy cones. This is basically, in our opinion, a stage of photoreceptor degeneration, and can be rather found in rather younger patients with RP. What is typical in our opinion is that they are swollen and they appear a bit puffy. They are large in size, and the borders of the cells do not appear as clearly defined as in a normal fovea. As I said, it can be a sign for early degeneration, because we normally would find them in the, as you see in the autofluorescence imaging, that it's on the border of healthy and degenerated cells, photoreceptors, and retinal. So we could see them also in a patient who had a macular edema, and you could see that even after the edema, the puffy counts are still visible. So yeah, on a baseline, on a lower line, you can see that there's the edema, and in the upper line it's gone, but still in 2020 there are puffy counts and AOs visible. Then we tried to establish the cheetah pattern. We call it like this as it resembles the fur of the animal cheetah. So it's nicely seen that there are rather homogeneous areas of dark dot-shaped atrophy. And we could observe them very often in RPGR mutations. However, they can be also seen in other RP patients. And what is typical, what you see in these patients, is there is a vast degeneration in the outer retina and then the outer nuclear layer. So these are not visible anymore on OCT imaging. And I also heard that one of the case reports, or I saw it, that there are puffy cones also.
Excuse me, 30 seconds left to conclude.
They're defined. So I'm curious what he will report on the puffy cones. And I thank you very much for your attention.
Thank you, Frederick. Very interesting findings. Thank you, and we will discuss about it after the other speakers. And I'd like to introduce the second speaker, Shohei Kitahata, from Yokohama City University, with the photoreceptor features in RP with the macular edema using adaptive optics fundus camera. Thank you.
Thank you for the opportunity to make the presentation at such a wonderful conference. I will talk about the photoreceptor features in retinitis pigmentosa complicated by macular edema. Cystoid macular edema is one of the common complications of retinitis pigmentosa and associated with the central vision. And adaptive optics can allow a non-invasive examination of the photoreceptor up to 2 micrometers. And it is possible to qualify the photoreceptor density and morphology using bone marrow analysis. Some studies have reported about the relationship between macular edema and the photoreceptors using AO examination. Decrease of photoreceptor density has been reported in diabetic macular edema and macular telangiectasia type 2. And also, the BRVO affected area had an irregularly sharp cone mosaic pattern even after macular edema had recovered. However, there is no report on ME with RP patients using AO examination. So in this study, we investigate the effect of ME on photoreceptors in RP patients using an AO fundus camera. This retrospective cohort study included patients underwent genetic analysis and AO examination. We divided the patients into 2 groups, those with a history or current illness of macular edema and those who had never had edema. For the analysis of AO, because it is difficult to analyze a perimacular 1 degree due to cone high density, the photoreceptor were examined at 4 points around 1.5 to 2 degrees and then averaged using measurement software. A total patients was 54 eyes of 42 patients. ME positive group was 30 eyes of 18 patients and 24 eyes of 24 patients in ME negative group as a control. There is no significant difference in age, visual acuity, EZ length, or axial length between 2 groups. The proportion of gene mutation in both groups are shown in here. there was no difference in the complication rates of macular edema by gene mutation. The left figure shows the photoreceptor density, and the right figure shows the photoreceptor regularity in both groups. Both density and regularity were significantly lower in the ME positive group compared to negative one. Next, we examined the correlation between photoreceptor and patient's age. In the ME negative group, there was no correlation between photoreceptor and patient's age. On the other hand, in the ME positive group, there was a negative correlation between photoreceptor and age. In other words, it was suggested that the ME positive group had a greater decrease in photoreceptor cells with aging. Furthermore, in the ME negative, in the ME positive group, multivariate analysis was performed using macular edema-related items and genetic variants. Density and regularity decreased with age, and there was an association with duration in density. In addition to that, there was a tendency for photoreceptor density with regularity to decrease more in patients with mutation of RHO, PRPF31, or PDE6 beta. So we found that 30 genes caused greater reduction in density and regularity. This is a result summary. Complications of ME in RP associated with photoreceptor loss, which decrease more with aging. In ME positive group, gene mutation, not the size of edema, a greater impact of photoreceptor loss. So the mechanism of CME in RP is thought to be multifactorial and is not completely understood. One of the most important ones has been noted to be mirror cell hypertrophy. As RP progresses, peripheral rod apoptosis occurs and followed by ectopic synapse in central macular cells, and then decreasing the expression of their major potassium channel, which causes them to synthesize excessive growth factors, resulting in mirror cells hypertrophy. Multivariate analysis.
Time to conclude.
Okay. Those genes were characterized as ROT dominant. So ROT dominant gene may have an imbalance in expression of retina and may be prone to edema, as mentioned earlier. So this is conclusion. There seems to be association between CME complications and photoreceptor loss, and early treatment is desirable. The photoreceptor loss may differ depending on the causal genes. That's all. Thank you for your attention.
Thank you. Congratulations for your presentation. And the first speaker is Daniela Rosa-Handel from Lyon's Eye Institute, Perth, and we will talk about early detection of localized cone loss in female carriers of RPGR mutations using adaptive optics imaging. Thank you.
So today I'll be talking about the role of adaptive optics imaging in early detection of localized cone loss in patients with RPGR mutations, especially the female carriers. So we know that RPGR mutations are the most common cause of X-linked RP, and also female carriers of RPGR mutations can be asymptomatic, or they can present with progressive retinal dystrophy as severe as male phenotype. In asymptomatic carriers, retinal structure and function is usually normal using conventional techniques like OCT or fundus autofluorescence. But these conventional techniques have shown some localized changes in some patients, which may be due to differential X chromosome inactivation at different developmental stages. So in this study, we aim to show the localized changes in cone density and retinal sensitivity using microperimetry and flood illumination adaptive optics imaging. So we used Maya microperimeter with 10-2 strategy. We performed Maya in 12 female carriers and 25 healthy controls, and measured pointwise sensitivity at 68 locations, which were 1 to 9 degrees away from the fovea. And also we performed rtx1 imaging in 8 female carriers and 10 healthy controls. And we measured cone density using the AO-Detect software at 12 locations, 1 to 3 degrees away from the fovea. And we defined pointwise sensitivity and cone density abnormality based on the standard deviation from the normal average, which was normal if it was less than 1 standard deviation below normal average, or it was a moderate defect if it was 1 to 2 standard deviation below normal average, or a severe defect if it was more than 2 standard deviation below normal average. All patients underwent complete ophthalmic examination, multimodal retinal imaging, including STO-CT, infrared reflectance, and autofluorescence imaging. So this is the protocol for Maya and AO imaging. So you can see all of the locations of Maya, which is 68 locations, 1 to 9 degrees away from the fovea. And also in this dotted area, you can see the 12 locations at which AO imaging was performed. So this is a typical 10-2 microperimetry, which shows the pointwise sensitivity at different locations. And also this is a density map, which shows cone density at posterior pole. And we performed cone density analysis on these 12 locations, which are 1 to 3 degrees away from the fovea. And they are corresponding to the locations of Maya. So the mean age of patients in the Maya cohort was 36 years old, and in AO cohort was 34 years old. And 7 out of these 12 patients were asymptomatic, and 5 of them were had normal visual acuity and normal multimodal retinal imaging. Severe pointwise sensitivity and cone density defect was observed at least at 1 location in 10 out of 12 patients in Maya and 7 out of 8 patients in adaptive optics imaging. And more interestingly, among 5 patients who were asymptomatic and had normal visual acuity, normal OCT, and unremarkable autofluorescence imaging, 3 of these 5 patients had at least 1 location with severe pointwise sensitivity defect, and 4 of these 5 patients had at least 1 location with severe cone density defect. So this is an example of a patient 36 years old, female with RPGR mutation. You can see that Maya sensitivity, retinal sensitivity was normal at all locations. But at cone density map, you can see that there are 3 locations with severe defect and 5 locations with moderate defect. So this patient was asymptomatic, normal visual acuity, normal OCT, normal fundus autofluorescence, everything was normal. And there's another patient, 26 years old, again, normal visual acuity and normal multimodal retinal imaging, but with severe defects on retinal sensitivity map and also cone density map. So we showed that microperimetry and AO imaging are feasible in female carriers of RPGR mutations. So we had performed this in 12 patients. And we also showed that AO imaging detects localized photoreceptor loss in asymptomatic carriers with normal ellipsoid zone span and normal visual acuity and normal other examinations. And also we showed in some cases that even with a normal retinal sensitivity, cone density declines. So it shows that maybe structural changes precede functional changes in these patients. And so we suggest longitudinal studies to evaluate the role of cone density and pointwise sensitivity in monitoring these patients, and also as a potential endpoint for future clinical trials. Thank you very much for your attention.
Thank you very much. Thank you for your presentation, excellent presentation. And we have a question from Pukrai Rishi, asking if we know of the adaptive optics findings along the hyperautofluorescence ring in retinitis pigmentosa. Would you like to answer this question? Did you examine the patients in the area between the affected retina and the sparing retina? What do you think?
This is the question for me, right?
Yes,
Okay, I'm sorry, I was not really sure. If,
but
okay.
it doesn't matter if the other speakers can.
Yeah, these were the puffy counts. They were actually in this zone visible in the hypofluorescent ring on RP, and this is actually right at the border which we normally see in OCT imaging. So it was not in the central foveola where we normally would see a rather normal mosaic, but right at this hyperfluorescent ring. And in OCT, there is no differentiation possible. So it's actually a nice tool to look at it on AO. And as I said, we think it's a sign of probably the start of degeneration, that it's swollen, but still there's a cone visible and no atrophy.
Okay, thank you. And I'd like to ask you if you can give us some practical suggestions about the image acquisition procedure. How many degrees, how many locations, what do you suggest us, Friedrich?
I think it really depends how well the patient still can cooperate. If the RP is not vastly degenerated, then progressed, then I think a larger view or the largest possible frame is nice to see, because then you can see in a montage actually also where there are still regions of rather normal mosaic, or where the RP actually starts. So and then, like, if the vision is decreased, I think it makes sense to just do it in the center, or like even focus more on the center, because sometimes they also can't focus well, so it takes a lot of time sometimes for these patients too. And I think for practical reasons it makes sometimes more sense than just focus more on a smaller scale.
Yes, what do you think, Professor Stanga, about the practical method of examining our RP patient using adaptive optics?
I think, well, congratulations to the three speakers. They're fantastic presentations, very encouraging towards the use of this technology. I have no doubts that we need to use more and more this technology. In fact, I've got a question for each one of the speakers. For Friederike, you've talked about Puffy cones. Do they change the way you diagnose and manage patients, and talk about prognosis? What do you tell patients when you see Puffy cones?
Yeah, that would be actually nice to be that able already to do it. At the moment, I think it's just rather a finding that has no implication. We are still not really sure what it is. It's just an assumption that it's part of the degenerated zone. But I think to translate it into clinical practice, there is still a way to go. So unfortunately, we can't.
Can I ask Dr. Kitahata? Congratulations again for another excellent presentation. My understanding of your work is that it seems to support the need to treat cystoid macular edema in RP. And one would be surprised how many patients with RP and edema are not being treated at the moment, when we've had treatments available for a long time. Are you doing any work looking at before and after resolution of the CMO in these patients to see any change, to what changes take place that you can see with adaptive optics?
Thank you for your question. Your meaning is how difference after and before the treatment to macular edema, right?
Correct.
Thank you. This is an important question, but unfortunately, those examinations with one-time point. So now we continue to examine the before and after treatment, and how different change depending on the treatment. So continue to examine.
So, yeah.
Can I ask a question to Shohei? Do you think that we saw during your very interesting presentation that the density is lower, density of cone is lower in a group of patients affected by macular edema? Do you think that the presence of macular edema can optically influence the ability of detecting the cones or not? Do you think that we can able to detect in an objective way the cone density, or the presence of macular edema can influence this?
Yes, thank you for the question. So the EO examination, it is difficult to examine the central macula because central macula have the cone high density. So now we try to examine the around the perimacular area, so 1.5 to 2 degrees, not to the center, not the central macula. Yes.
Okay.
I think we need to move to the session number 2.